Good morning, viewers, and welcome to another edition of Kakaki Cancer Awareness with Dr. Denise EJOH, the CEO of Commode Cancer Foundation, in partnership with AIT. Today, what we're talking about, a conversation with Dr. ZAINAB SHINKAFI-BAGUDU, tackling cancer inequalities in Nigeria. ZAINAB, morning.
Good morning, Denise.
Can you hear me? You're looking very nice.
So do you.
And you actually got it right. It's very, very clear now. That's a good one. So together we fight, together we win. Let's start it. We're championing our cause of cancer awareness in Nigeria. So as we draw close to the World Cancer Congress, let's start to enjoy a lot of conversations. And today we've got our guest, Dr. ZAINAB, who will be, for purpose of ZAINAB is my friend as well as Her Excellency and all those other titles. So please just bear with me and her bantering as we call ourselves. And she's my guest, and today we're going to be talking about nation and the driving change in Nigeria at this point, and how far she's been able to help us make a difference. Nigeria has a population of about 200 million people, and 1 in 2 people globally will get cancer. I keep saying this thing because it's ravaging the world, and the more we hear it, the more we maybe start getting aware of watching ourselves and watching what's going on in our lives. And approximately 70 to 80% of people with cancer will die, unfortunately, across the world. In Nigeria. So let's look at this conversation with the partnership we have with AIT. We have been discussing a lot on cancer, and we're privileged to be able to talk about a lot of things. So today, I want us to really look at what is going on in the cancer space. I'm going to repeat our topic: tackling cancer inequalities in Nigeria. A conversation with Dr. ZAINAB BAGUDU. ZAINAB, you're ready for me. But before we go on to this, I need to also remind our viewers of our giveaway. Our giveaway August is taking place at the end of the month, and September comes on very soon. Together we fight, together we win. Let's start our conversation. Relax, share, follow, and subscribe to the Commode Cancer Foundation. Our guest is our guest. Dr. ZAINAB is a pediatrician. ZAINAB, your medical terms, please God, don't use the ones I don't know how to spell.
Child health specialist. A child.
It's just the pronunciation is long.
I'm sure you're
pediatrician. I know, it's just tongue twisting, man. And a global advocate on women's health with a particular focus on cancer. She's the CEO founder of Medicaid Cancer Foundation and the MD CEO of the Medicaid Radio Diagnostic and Clinics. I think it's all around Nigeria, I presume.
Yes, absolutely.
Exactly. Additionally, she serves as the chairperson of the First Ladies Against Cancer, and recently she has been appointed as the senior advisor to the Minister of Health on Women's Health and Advocacy. And she is also a board member of the Union for International Cancer Control. So today I want to say thank you for taking time out to chat with me and to create some awareness of where we are, where we're going, and what your views are on changing the narrative for those of us that live with the disease. Together we fight. We are all united against cancer. So together we fight, together we win. ZAINAB, are you ready for me?
Can one ever be ready for the hurricane that is Denise? Let's try.
I'm not that bad. I'm very good. I'm actually very good. Okay. Dr. ZAINAB, let's go. As a leading advocate for cancer care in Nigeria, but not just in Nigeria. I'm doing Nigeria, but let's talk about it. Focus on Nigeria, but recognize that it's not just about Nigeria for you, right? What do you see as the most significant barriers to equitable cancer treatment in the country?
Well, thank you, and good morning again, everyone. It's a pleasure to be on this program with AIT and the Commode Cancer Foundation. Denise, a dear friend, someone who has been navigating the very complex world that is cancer. We celebrate you as always, and I'm always willing to add my 2 cents to the issues that we have. The barriers in cancer, we can cancer control better still. And the other word that is significant in your question is equitable. So when we talk about cancer control and we look at it from different perspectives, when you talk about equity, what is fair? We're not saying equal distribution, but 50% of the medication might be ideal for one country in Africa, but it's not ideal for Nigeria as compared to what you have in a high-income country. So when we're trying to talk about equity, we're talking about a fair and just distribution of solutions that has to do with cancer. The barriers are many. Some of them are related to the medical, technical, scientific aspect of it, which is what we as medics tend to focus on, and to a large extent, government as well. But for us in Africa, from my own personal experience and from the research that is available to us, shows that the sociocultural barriers are actually the greatest. And when I say sociocultural barriers, I mean things like the perception to cancer. In the first place, do the majority of our people believe that cancer exists? How do they seek help? What is their health-seeking behavior? Where do they go first? Do they go to the hospital, or do they go to a faith healer or a traditional healer? Again, that is usually the norm. And all these things leads to a late presentation. Cancer is staged in different stages, 1, 2, 3, 4, depending on the severity of the disease and metastasis, that is movements to other parts. So you have a primary cancer in, say, the breast, and has it moved to the lungs or to the bones or to the brain? And this is how the complexity of the staging evolves. For us in Africa, Nigeria, low middle income countries, we tend to pick cancer up in the later stages because of the awareness and because of these behaviors that I have enumerated. People tend to go until it is at a later stage, and it is much harder and more expensive to treat. Then, of course, the big issue is the infrastructure that is available. What hospital can they go? How much access do they have? We live in a terrain that there are many hard-to-reach areas. Hospitals are not readily available within traveling distance for most people. And even when they are, do they have the facilities to diagnose, to treat, and to even help them with the palliative care along the entire spectrum of cancer? So availability and access to treatment, access to facilities, and what are these treatment modalities that we're talking about? We're talking about surgery, chemotherapy, that's the drug use, and radiotherapy, which is where most people tend to focus, and about the numbers of radiotherapy centers that we have available. How well are we maintaining those centers, even the ones that give chemotherapy, both in the public and the private sector? What are the infrastructure available to back them up in terms of the power and other things that are required to keep a medical facility of that high standard running? These are often deficient, and all that encompasses in a weak health system. Who are the people that are operating these machines? We can build so many fancy cancer centers, but do we have enough human capacity, human capital to deal with those centers and operate the machines and make the diagnosis and treat the patients? Just before we were listening to the news about the new law that has been passed to keep healthcare workers within the country, and the current debate that is going on in the country, we have seen a massive influx of healthcare workers to high-income countries, with active mobilization by these countries, especially after the advent of COVID. So in summary, these are some of the factors that we face, and all included in all of this, of course, the big overlying issue is the financials, the financial ability to be able to be more aware, to access information that is available, to access diagnosis, and also to access treatment. you need money to do that. The government needs funding to do all those things. So there's a financial issue overlying all of this.
Thank you. I like the way you started this, because one of the things that a lot of people forget or don't recognize is the socio-economic challenges that people that are diagnosed with cancer face, and the impact of its hindrance on stepping out of the first, stepping out from being late presenters to actually early presenters. Because if we didn't have those challenges, we knew what it was, then we have a better chance of addressing it. And one thing I did find on the homework because of you was to find out, because of you, so hear what I said, is what is the word cancer in Hausa?
What did you find?
And I found it was called Ciwon Dajin cancer.
Ciwon daji. Ciwon daji, even that in itself is an indication of what I was talking about. There are two words. There's Sankara and there's Ciwon daji. Ciwon daji means disease of the bush, disease of the forest. So something in the forest, alien and unknown. So that is the word for it. And you'll find that in most of our languages, it is similar.
That's why I asked the question, because I've gone on homework, if we're going to address this disease even in Nigeria, we've got to start knowing how to take this English language back to our people, to tell them, wake up, all these things you're calling may not actually be a big problem. But everything else you've actually recognized are really our key issues. So how have you personally how have your personal experiences, and professional background shaped your approach to addressing these cancer disparities in Nigeria? And when I ask this question, I'm looking at it from the fact that you've been opportuned to work outside the country, live in and out of the country, engage with a range of stakeholders in the cancer space. So from that point of view, can you give us your comments on that?
Well, I think this is a good place to talk about my journey. A lot of people, usually what they ask me is, why cancer? And it came about as a result of my exposure, like you said, my training in a high-income country. After my basic degree in Nigeria, I was able to train in child health in the UK. And over there, I saw the way that I actually had a breast lump, and I went through the system removing that breast lump. They have what is called a one-stop clinic, women clinic, and it's one stop. A woman with a lump can go into a facility, get scanned, get a mammogram, get a needle biopsy. Almost immediately, you get the results. If you need to have a chunk of the tissue taken out, they take it out, they give you an appointment, and it goes on like that. So it's a one-stop clinic, and it eliminates delay. So when I came back to Nigeria, I was inspired, and I found, of course, as a pediatrician, I was running my clinic in Garki Hospital, which is a public hospital, and I come across a lot of women. In our environment, it's mostly the women that bring the children to the hospital when they're sick. And these women use the opportunity, seeing me as a woman in northern Nigeria, they relate to me. And they ask me their own personal problems. It ranges from, what's this in my breast? Do I have a funny vaginal discharge? Although that wasn't my area of expertise, I immediately realized the great need to have people that are able to educate the women, and in turn, we would have better outcomes for our children and the child health. That's how the Medicaid Cancer Foundation was started, and we were creating awareness. So I used my experience, like you asked, in a high-income area environment where everything was available, to bridge and try to bridge that gap, to provide it at our own level. So that awareness that was greatly missing was what we focused on to start with. We still do go into the grassroots, into the community, into schools, into gatherings of women in various places, men as well, to teach them about the basics of cancer, the signs and symptoms they need to look out for. On record, we have about over 120,000 cases of cancer every year in Nigeria, but there are probably a lot more people that are undiagnosed and undetected. So the data is quite weak, but we try to educate as much as we can so that we can start to pick it up earlier. And at that point, they now tell you, what can you do? How can I go to a facility and what do I need to do? So going through all that, it makes you feel we need to work with private partners, form credible and sustainable partnerships that will give access to some of the things that patients that are navigating cancer or even trying to reach a diagnosis are going through. And that started my work with governments within the country on one hand and global partners outside the country in another hand. These partnerships enable us to provide better access to all the aspects of cancer control, treatment, diagnosis, palliative care, and so on. When I say working with government, we started to advocate. A group of us came together and formed what is today known as the Cancer Health Fund. We formed the basis for that advocacy, and we were able to successfully achieve the Cancer Health Fund. It was initially known as the Catastrophic Health Fund, but the Cancer Health Fund exists today, and it gives patients access to funding through some tertiary hospitals for some of the common cancers in Nigeria. Then, of course, we have other issues, like I said, diagnosis, and again, working with governments to try to provide more diagnostic centers. You mentioned that I chair at the moment the First Ladies Against Cancer, and that's another aspect of my work, that I was opportune to have a platform when my husband was the governor of Kebbi State, and we're able to implement quite a few changing initiatives in the state, such as having a plan, having an indigent cancer fund, having access programs that the state went into partnership with some major pharmaceuticals that are providing manufacturing the drugs, and the government pays a certain amount. The foundation pays a certain amount through our own fundraising, and then the patient is able to afford it at a very low price. To be honest, in Kebbi State, it was actually given free for breast cancer and prostate cancer, those two cancers. So those are some of the things that we work on successfully. By being a board member of the Union for International Cancer Control, I'm able to know what opportunities exist globally and to bring them back to our own country, particularly in the area of training and fellowships for our healthcare workers, our oncologists, radiologists, radiographers, to help them improve their own skills so that they can do better for the people. But like we said, we're seeing a lot of them leaving the country, unfortunately.
Okay, I think we are running out of time. Yeah, I think we're running out of time. So I'd like you to close this conversation for me and tell me quickly how can we leverage on this? Let me put it properly. How have you leveraged Nigeria's significant population to drive partnerships that position the country?
Well, Nigeria is
as sharply as you can.
Okay, high population country, Nigeria. The best example I can use is the human papillomavirus vaccine that we successfully advocated for with the help of so many partners, the Federal Ministry of Health, UNICEF, Gavi, all these organizations came together, and eventually Nigerian girls are able to access this vaccine, which is totally a game changer. And if you take the HPV vaccine at the right time, cervical cancer is one cancer that we can totally eliminate. It was a great inequity, and now we have the opportunity to close that gap and offer our girls a future free of cervical cancer.
Awesome. Thank you. Sorry, we've run out of time. So many things happened at the same time. So let's look at it from this point of view. I want to say a very big thank you to you for joining me today. I look forward to chatting with you more on all these things that are going on, especially at this time. And also, I have to say, I hope and wish you all the best as you contest for the president of the UICC in Geneva this year. I hope, fingers crossed for you.
Yeah. Thank you very much, Denise.
You know, we're behind you all the way, anytime.